everybody, and welcome to today's episode of Physician Pathways. My name is Colin Dunn, and I'm here with my co-host, Mariah Davis.
Oh, hey, guys.
And with us today, we have Dr. Hari Nair. So welcome to the show, Dr. Nair.
Thank you very much for having me.
Yeah, and just as a little bit of a background, Dr. Nair is a current fellow in Hematology Oncology at St. Louis University School of Medicine. Before this, he was a resident at St. Elizabeth's Medical Center at Tufts University in Boston, Massachusetts. He completed an IM residency and served as the chief resident from 2019 to 2020. All right, well, Dr. Nair, again, thank you for being here today. We're really interested in talking to you and learning a little bit more about your specialty. Just as a little bit of background, we M2s just finished our Hem-Onc block, which I think many of us found a little challenging, but it was fun along the way. So that was good.
That's great to know.
Yeah. All right, well, Dr. Nair, I guess just to get started.
What do you think is the most important thing medical students should know about your specialty?
Yeah, so I think there are several things about Hem-Onc that makes it unique, at least in my mind. One of the most important things is that it's a field that's evolving very rapidly. So you'll literally see new drugs coming up every week, every month, guidelines changing, and therapeutics just evolving so rapidly. So it's a very exciting field, a field that has a lot of change and something that you'll never feel bored of or be stagnant in. So I think that's one of the most unique things that I love about the field.
You said it has a lot of change. Do you feel like there are some common procedures or like standard patients that you see in your practice?
Yes, so that depends on the type of practice you're in. So in generally for hematology and oncology, you could say it's a practice where people kind of tend to do three different types of practice. One is purely academic. The other is purely private practice, and the third is some sort of combination of both. In the private practice, most people see pretty much all solid tumors. So the majority are breast cancer, lung cancer, gastrointestinal cancers, genitourinary cancers, and a little bit of benign hematology. So things like anemia, thrombocytopenia, thrombosis, bleeding disorders. Whereas in academic centers, it's a little more specialized. So you have a lot of malignant hematology, which includes acute leukemias, lymphomas, myelomas. And so you see a lot of specialized treatments there. So as a general hematology oncology practitioner, I'd say my most common patient would be a breast cancer patient or a lung cancer patient, or a patient with anemia who's being referred for evaluation.
Very interesting. Dr. Nair, I guess kind of to follow up with that, you talked about the different settings of practice, with academic versus private practice. I was wondering if there's any difference in like practice as far as being in a more urban area versus a more rural area. I mean, are there hematologists and oncologists in rural areas, or are they mostly concentrated in cities?
So they're definitely much more concentrated in cities. If you go to a rural area, you'll typically see a hematology oncology provider kind of being a jack of all trades, so kind of seeing solid tumors as well as doing a little bit of malignant hematology, definitely benign hematology. However, the more complex patients, like patients with newly diagnosed acute myeloid leukemias who need induction, or people who need a bone marrow transplant, are typically referred to a tertiary center, which is usually in one of the larger cities in the state.
Yeah, very interesting. Well, I appreciate that answer. Another question I had, as we look forward, obviously the students here know about residencies and fellowships. Can you talk a little bit about what training looks like for Hem-Onc, from graduation of medical school and on?
Absolutely. So hematology and oncology. So oncology in general, there's surgical oncology, there's radiation oncology, and medical oncology. And so hematology and oncology is medical oncology. And to get into that, once you finish medical school, you need a 3-year residency in internal medicine. So once you finish your 3 years of internal medicine, you typically apply for a hematology and oncology fellowship. Now, the vast majority of programs are a combination of hematology and oncology, where you will be trained in solid tumors that encompasses, pretty much all the tumors that we just talked about, like breast, lung, GI, GU malignancies. You also have hematology part of it, where you deal with all the malignant hematology, cancers like leukemias, lymphomas, myelomas, and benign hematology. There are some programs that just do oncology. That's a 2-year fellowship where you'll be trained just in solid tumor management. And there are a few programs that just do hematology, so where you'll be just dealing with leukemias and benign hematology. But those are much less frequent than the combined hematology oncology 3-year fellowship program.
So would you be able to like specialize or subspecialize beyond that, or is that kind of like the peak where you hit a wall?
So there definitely is specialization beyond hematology and oncology fellowship. A lot of people don't do that. They just try, finish their fellowship and go out into practice. But if you want, you can do a 1-year fellowship in bone marrow transplant. So that'll be one fellowship. And there are also certain fellowships that certain centers in the US offer where you can specialize in thoracic malignancies or GI malignancies or breast cancer. Those are non-ACGME accredited fellowships for 1 year. And then you have the bone marrow transplant fellowship. So you could do any of those after finishing 3-year HEMONC fellowship. But I would say more than 90% of graduates go on to practice after finishing the 3-year fellowship.
Going back to just fellowships in general for HEMONC, what does your day-to-day look like? I mean, you're still in the hospital now. Do you stay this late most days, or is that a normal schedule for you?
Not really. I just stayed late today for the interview, but actually it depends on what rotation you're in. So most programs usually have a lot of inpatient service in their first year of fellowship, and second year and third year is mostly outpatient based and electives. So my day and how many hours I work in a day depends on what rotation I'm in. So for example, here at SLU, you have inpatient hematology service where you take care of all the acute, leukemias, lymphoma patients, myelomas. And then you have the consult service where you are not the primary, but you get consulted on by other services for newly diagnosed solid organ malignancies or, people with acute hematological issues like thrombocytopenia or anemia. So when you're in the inpatient hematology service, your day typically begins around, 7:30, 8 in the morning. You're around from 8 to 11 or 12. And then you have a noon conference from 12 to 1. And then after that, you either have clinic or you kind of just, make sure that the patients are doing well. And you can typically leave the hospital by around 5 p.m. So that's how the day looks like in inpatient hematology. On the consult service, I would say about the same thing. You come in at 8, 8:30, and then you just kind of get new consults through the day. And then you're done by 4:35 p.m. When you're in clinic, typically here we have half-day clinics. So your half-day could be either in the morning from 8 through 12 or in the afternoon from 1 through 5. And the rest of the day, you get time for yourself.
Yeah, I guess segue off that opens up we had a question come in from the student, and they were just wondering how research plays into your fellowship. On those half days, would you have time to do research if you wanted to? Is research required?
So a little bit of research is required, but how deep you go into research is absolutely dependent on how you want to do it. So I am currently involved in a couple retrospective studies, and I've published a few case reports. But if you want to do basic science research or involved in clinical trials and prospective studies, you're absolutely welcome to. In first year, it might be a little difficult because you're busy with the inpatient and consult services, but in second year and third year, you do have plenty of time to do that.
Awesome, thank you.
Very nice. I might have missed this, but with you like consulting and stuff, do you guys have on call, like you have to be in the hospital vicinity to help with patients, or is that kind of like more a ER ICU type thing?
That's a great question. So when you're in the inpatient hematology service, so during the day you see patients, you have your own service, you run the service with your attending physician and residents, and during the evenings and overnight you're on call. Which means you take calls from the ER if there is a patient with an acute hematologic emergency. You take calls from outside hospitals if patients from a tertiary center or other peripheral hospitals need transfer to our hospital for higher level management. you also take calls from patients if they have an emergency and they are trying to reach the oncologist on call. So that also is part of your job when you're in the inpatient hematology service.
Oh, very cool. I guess, Dr. Nair, if I can take you back to when you were a medical student, was HEMONC kind of always your goal, or was there an experience that you had that kind of pushed you in this direction?
So I definitely did not have a specific goal in mind when I was in medicine. So I just wanted to try the different specialties, see how things are. And I think it's a variety of factors that made me interested in HEMONC. One is just, just the field is so exciting. There's so many new drugs and new developments happening at a very rapid pace. So you never get bored practicing HEMONC. That is one thing. The other thing is I am more of an outpatient type of person. So HEMONC, if you're in private practice in hematology and oncology, you do have pretty much all of your work is outpatient based. So that is the other thing. And then growing up, I had more of an affinity towards, chemistry and chemistry-based sciences and specialties. So, HEMONC is kind of along the same lines. So that was another reason. And then the other thing is the relationships you build with patients, because you are seeing patients on a long-term basis. So they you kind of become their primary care physician, so to speak. You're involved in their care pretty closely and for prolonged periods of time, and it's a very satisfying specialty. So I think a combination of all these reasons is what made me interested in HEMONC.
Well, that does sound beneficial. Continuing on that track of like thinking about when you were in med school, what could you have done differently, or what did you feel you did well preparing for your rotation or like selecting a HEMONC rotation if you're a fourth year student?
I wouldn't say I could have done anything differently or better, but if you ask me what can be done while you're in medical school, I think trying to take an elective in HEMONC is definitely a very good thing to do. Especially HEMONC consults gives you like the breadth of the specialty, because you're seeing acute issues in the hospital as well as newly diagnosed solid tumors. You're seeing newly diagnosed liquid malignancies. So it's definitely a very good exposure to HEMONC. So if you want to consider, if you have the option of doing an elective in third year medical school, you definitely should do that in HEMONC, at least for a couple of weeks or a month. And then HEMONC being mostly an outpatient-based specialty, there's plenty of clinic opportunities available too. So if you're a third year medical student or fourth year medical student, you're always welcome to shadow the fellows or the attendings in clinics. A half-day clinic would, you would be able to see pretty much a lot of benign hematology, different, solid tumors. And here in SLU, we have different attendings specializing in different types of tumors. So if you're interested in lung cancer, you can shadow a lung cancer attending. If you're interested in GI malignancies, you can shadow a GI malignancy attending. And a lot of these attendings also see benign hematology as part of their daily work. So you'd be getting exposure to both of them at the same time if you choose to do a half-day clinic.
So Dr. Nair, I guess we've been talking about the good things about HEMONC, and I'm just wondering, are there anything that, I guess, any circumstances or any things within the field that you find particularly challenging? I guess like mundane cases or other things that just make you dislike HEMONC at least a little bit?
I don't think there's anything that I completely dislike about HEMONC. To answer your question about something that's challenging, I think it's one of the things that I mentioned earlier. One of the things that makes it exciting also makes it challenging. The fact that, things evolve so rapidly. So guidelines keep changing, newer drugs keep coming into play. So you always have to stay on top of your game every day, literally, to, be a good HEMONC practitioner. So that definitely is a challenge, but I would say it's a good challenge. The other thing is just the, as I was mentioning, the relationships you build with your patients. Sometimes, no matter what we do, some malignancies are just too aggressive. And despite all treatments, you will see patients, passing away. So you will lose patients. So that, again, can sometimes, be emotionally a little upsetting to the provider, especially if you've built a long-term relationship with the patient. So that is something that you just learn to live with and understand. I'm sure it's there in other specialties too, but maybe a little bit more in HEMONC. So that's just one thing that we need to know.
Yeah, it's one thing I'm not looking forward to as a physician. But you talked about how all the drugs and like policies come out very quickly.
Yeah.
Do you know how physicians in the field like stay on top of it? Like, is there kind of a nationwide guideline of like, hey, you need to review these things every so often? Does SLU have one? How does that look?
Absolutely. So it's called the NCCN guidelines, or the National Comprehensive Cancer Network guidelines. So this is free and accessible to all. All you need to do is go to NCCN, register for an account, and then they have guidelines for each separate malignancy as separate PDFs. And that keeps getting updated pretty frequently. So if a new drug gets FDA approved, or a new diagnostic modality gets approved, it makes it into the NCCN guidelines. So we literally look at NCCN guidelines every single day of our practice. So if I'm in clinic and seeing a patient, an NCCN guideline website is open on my computer. So that is pretty much the go-to reference that all of us use. And then, up to date is pretty good as well. And then we do have a lot of, national meetings and symposia. So for the hematology, we have the American Society of Hematology, or the ASH, which meets every year at a specific location, and then all the new papers and the new trials are presented there. So, as trainees, as residents and fellows, you get discounts to attend those meetings. And then the same thing for oncology, there's ASCO, or American Society of Clinical Oncology, which holds a meeting every year as well. And it's telecast virtually too, so you can go there and keep yourself up to date. So lots of resources, yes.
That sounds like it. I'm sure that's very helpful in your practice.
Absolutely, yeah.
Well, Dr. Nair, we had a question come in from a student, and they were wondering if you think that it's important to have an idea that you want to pursue HEMONC during the intern year of residency, and if so, what can one do during residency to improve chances of matching into the fellowship?
Absolutely, yeah, that's a great question. So in intern year, I would say in the first 6 months, just take your time to kind of see how different specialties are, to see how your interest in the science evolves in those 6 months, and how the day-to-day practice of a physician in that particular specialty is, and then you can make a decision based on that. And if you do choose HEMONC, then I would say, start trying to reach out to the attendings in the HEMONC department of your program or your hospital. I'm sure a lot of them would be willing to, let you shadow them and work with them in clinic. So that'd be one thing to do. The other thing is if your program gives you the option to choose clinics on your ambulatory block, depending on what specialty you want, try to get into more HEMONC clinics, because the more you work with attendings, then the closer they can observe you, they can work with you, they can give you a stronger letter. So that's definitely one important thing. The other thing is towards the second half of your first year, or in your second year, if you do have the chance to do consults or electives in HEMONC, please do consider that, because that'll also be pretty helpful. And then in hospitals that do have an inpatient hematology service, like here in SLU, for example, pretty much all the residents rotate through the inpatient hematology service. So that's a good rotation to get exposed to malignant hematology. So a combination of all these, I think, would prepare you well, would also give you good face time with the attendings, and that'll set you up for a good letter.
So, like, current M1 was thinking about how to spend their summertime, and they're like, HEMONC's on my mind. I want to start shadowing, or I want to do research. Is there anyone in like the SLU physician group that you would like really point them to, or would you just say like, yeah, if you can look up anyone in the group, like they're all good to contact?
Yeah, I think they're all pretty much good to contact. They're all excellent attendings here. If you want to do it in a more official capacity, I think, reaching out to the division director, I think would be a reasonable option. But other than that, all the attendings are pretty receptive, very helpful. So you can reach out to any of them, and they'll happily let you shadow in their clinics.
Well, Dr. Nair, you had mentioned earlier about like some of the challenges that you face within HEMONC, and one of them was that you will often lose, or not often, but sometimes lose patients. I'm just wondering, how as a physician do you work to manage that? I guess do you rely on your support structure at home, other things that you do? It's like what is there within the world of medicine to help with that?
Absolutely. So I think one of the most important things is your colleagues and the relationships that you build at work. So I'm very lucky to have an excellent set of co-fellows and attendings and nurses, and these are the people that I work with every day. And kind of being able to share what we think and what we feel with them, and I think that is certainly very important. The other thing is, just accepting the fact that you've done your best for your patients. Sometimes it's just not possible to do, not possible for everything to go the way you wanted things to go. That'd be the other thing. And then the other thing is, every day, for two patients that you're not able to do anything, or for two patients that you lose, you're able to help 10 patients and see them get better, or, go into long-term remission, or even get cured. So I think that kind of offsets it. So you just have to learn to kind of look at the bright side of things, I would say. The other thing is, within medicine, I said, there are a lot of people in the hospital itself who are your support. There are wellness resources available as well that's accessible, hospital-wide for employees. And then also having something outside of medicine that you can just get your mind off. I think that's pretty important too. So I enjoy, bird photography. So that's something that I do as a hobby. So, going out in the woods and, capturing some bird photographs, I think definitely helps me, unwind and relax and kind of recharge.
Very nice. Do you have any schedules that you don't compromise on, that you have to do this in the morning? It just kind of helps you prepare for your day, or what happens when patients kind of get backed up?
Right. So I think one of the most important things is communication in HEMONC, because it's a very, it's a specialty that has a lot of players involved. So you're working with your clinic navigator, you're working with the outpatient clinic nurse, you're working with multiple different attendings who are taking care of that patient. You're also working with social work, with case management, a lot of different things. So one of the first things that I do in the morning is kind of look at my inbox and make sure that all the messages are replied to and things are taken care of. If that's done in the morning, then honestly, 40% of your work is done. The other thing is just, in terms of, I see how the day is. So for example, if I have a half-day clinic in the morning, I see how busy the day can be. It can vary. You can see anywhere between 3 to 4 patients in a half day, all the way to 12, 14 patients in a half day. So you kind of have to make a plan as to how you're going to tackle it. So if it's a busy day, then you just have to increase your pace and try to do things faster, and then try to do your notes later on. And kind of adapting your day according to how the day looks like, I think is the most important thing.
Dr. Nair, we just had a question come in, it looks like, and the student was wondering if you get any training in palliative care for working with terminally ill patients.
So that's a great question. And so when we're in the consult service, we work closely with the palliative care physicians. So a lot of times we're sharing the same patient, so we have a lot of discussion. We're involved in family meetings together. Officially, at least right now, it's in the SLU HEMONC program, there is no palliative care elective or rotation that's available. But if you want to, you can request it as an elective. But I'm sure in certain other places, palliative care is built in as part of the curriculum. So here, if you want to, you definitely do have the exposure available, but it's not mandatory as part of your curriculum.
Alrighty, and it looks like we had another question come in, a little different, but how do you manage to keep track of your notes on a busy day?
That's a great question. So what I do is I just, if it's a busy day, there are tons of patients, I just open notes and just put in the key points that I need to do, need to know, like, so key imaging results or important plans, just as bullet points, so that I know what's exactly in there and it's in the note. And then once I finish my clinic, I go back and then finish my note. That way I know what's in there and so I can build on that.
Speaking of trying to manage kind of a busy schedule, do you have a spouse or kids like outside of medicine?
I do not have a kid. My wife's in medical school as well. She is doing her master's in public health. So, we're both kind of in medicine. I don't think that, yeah. So, yeah, we're both in medicine.
How do you manage like spending time with each other? Is it just something that like you have to prioritize and schedule in, or do you guys be spontaneous about it?
I think we're just spontaneous about it. Like, once my work's done, I can come back and unwind and spend some time together. Some days are busy, especially if there's an exam coming up and stuff like that, then I usually tend to study at night. But usually I always, go home and unwind a little bit. I think that definitely helps.
Awesome. Yeah, that hits close to home, Dr. Nair. I also have a wife who's in medical school, so it's good to know that you can that you can make it work if you have to. So
yeah, it's definitely manageable, and I think it can go both ways. So if you have someone, if your partner's in medicine, then they also understand what you're talking about. So you can have conversations related to what happened in the hospital. So that could be advantages to you as well.
Yeah, well, great.
Yeah.
And it looks like we had another question coming in here. So what procedures do you do typically in hemo?
Yeah, so the most common procedure we do is bone marrow aspiration and biopsy at the bedside. So, when a patient comes in with pancytopenia and you're worried about an acute myeloid leukemia because you see a blast in the peripheral smear, then most important thing you need to do is to make sure that they don't have a clonal bone marrow process such as an acute myeloid leukemia, chronic myeloid leukemia, or acute lymphoblastic leukemia. And so a bone marrow examination is critical. So pretty much all of our procedures is bone marrow biopsy. And when you're in the inpatient service, I do anywhere between, on a 2-week block, I do anywhere between, 3 and 15 bone marrow biopsies. And those are all done at the bedside. And, so that's the most important procedure that we do. On top of that, we also do an Ommaya reservoir tap. So a lot of people getting intrathecal chemotherapy get an Ommaya reservoir placed. They're placed by neurosurgeons. But once placed, to administer chemotherapy through that, it's typically done by the oncology provider. So we do that as well.
Well, Dr. Nair, I think we're coming to the end here, at least of our question list. So before we let you go, do you have any last pieces of advice for medical students?
Yeah, absolutely. So I think, when you're going through medical school, keep an open mind and try to imbibe everything that you're learning. So, and try to, keep an open mind. And when you're going through different rotations, try to see which of these captures your interest the most. And it could be anything. It could be the science of the specialty itself. It could be the workflow. It could be the type of patients that you see. It could be reimbursement. It could be pretty much a lot of things, or it could be a combination of any number of these things. And whichever you think, attracts you the most, or whichever you think you can see yourself thrive in 10, 15 years down the line. So if you're working with an attending, kind of try to visualize how his or her workday goes, and try to visualize yourself doing that 10 years down the line or 20 years down the line, and ask yourself if you'd be happy doing that. And if you think you would be, then that's a specialty for you.
Yeah, it sounds like awesome advice. Well, we really appreciate that. As I think we have a lot of M1s and M2s. It seems like we might have some older students in here as well, but just to have your sights set, and I guess it's good to know what to be thinking about as we progress through medical school. That's great.
Absolutely.
Well, thank you so much for your time. If anyone else wants to stick around and talk to any of us in Physician Pathways, or if Dr. Nair wants to stick around and answer other questions, the Zoom will be open till 7. But other than that, thank you everyone for showing up.
Thank you.